Thank you very much for being here. Paul needs no introduction. Most of you will know he even played a role in NHS London in the past, or the Strategic Health Authority in the past. So welcome, and you've seen where we are. We're really focusing on integration. So, Paul, any thoughts to start off with?
Okay, a couple of minutes on barriers, and a couple of minutes on what to do about barriers, and then a minute on the Commission. It seems to me the first thing is I think we have all outsourced the way to describe this to Jeremy, and he's come up with the right way of describing it, and I think that's what the language we need to use is the language that National Voices has said we should use, and it works. Having done it with real-life people, it's a very different thing to talk about coordinated person-centred care than integrated care, and so that's the first thing about language. So on barriers, I think one of the things about integrated care that is most significant is it keeps on not happening. Intellectually, everyone thinks it's a good idea. Probably emotionally, everyone thinks it's a good idea. But very, very little care is remotely integrated. And I think it's because we underestimate the passion in favour of fragmentation. People may find that an odd thing to say, but people are passionately in favour of the things that they do, and the things that they do are very fragmented. And we, somewhere on this Monday morning in London, a district nurse will be really pleased that she's become a specialist district nurse. And she'll have been promoted into that position, and she will then become part of the problem of integration. And I think we've set up a system, merit awards, a system which rewards that passion for fragmented care. And then we ask people not to do it, and they think, what on earth are they going on about? So I think, we have 60-odd years of passion for fragmentation, and we've rewarded that, and suddenly turning that round needs a lot more passion for integration than I think we've been able to get into this discussion. Secondly, behind that individual passion is an intense organisational fragmentation that's been there for 60 years. For all sorts of reasons, Bevan set up a set of small businesses called GPs and a set of nationalised industries called hospitals. These are very different organisations. And the notion of saying get together is actually organised, and now we've constructed a social care market, which is a range of very small private sector organisations, the voluntary organisations, and some very large voluntary organisations. These are very different organisations, and getting them together. I remember, when I was starting to work with CCGs, when people who spent their lives as GPs walked into large SHA offices and saw hundreds of people sitting behind desks, they were stunned at what on earth went on in these places. Right? And equally, when people like me who've only worked in large organisations go to very small organisations, we're stunned at how small organisations can achieve anything. But actually, so we have a real organisational problem which goes against. And lastly, we've done, in terms of a barrier, we've been very successful, I think, in improving the value that each part of the health service produces. So we can now get knee replacements on a day case surgery when it was 10 days, only probably 10 years ago. So we've improved the value of bits really well, but most of that value is lost when it's not joined together into a series of into a value chain, into a supply chain management. So we've got people working very hard improving their value, which then in my mind sort of evaporates immediately. So the knee replacement is going very well, but then the physio doesn't turn up and the knee locks, and actually value has disappeared. So by driving value, as we've done successfully inside organisations. So I think what other industries do about this sort of problem, because I think the thing to say about these sets of problems is the division of labour in health and in most other industries is a really good thing. We're not saying everybody should be doing everything. The division of labour has saved thousands of lives and relieved a lot of pain and distress. But what happens in other industries is the division of labour is organised through a supply chain manager. So somebody is more powerful than the cardiac surgeon who says, it's my turn to step into this patient at this particular time. Someone says, no, the patient has got a pathway and you cannot do that at that particular time. And that is organised in other industries with someone more significant than the different bits of the division of labour. And I think within the current architecture of the health service, I think there are three different bits of the way in which this that can empower supply chain management. One is a thing that I've been working on with a number of GPs, which is an outcome-based contract system. So it's one of them is called COBIX, but they're around the country, and I know people in London are exploring this. But it's actually to say, what would it mean if for the frail elderly, what is the outcome? I did a meeting in Oxfordshire with a whole bunch of old people's groups and said, what's an outcome you want? Talk about an hour, that's all. They said, you spend a lot of money on us. At the end of you spending money on us, we'd like to be more independent at the end of that than we are at the beginning. Actually, the reverse is usually true. And when you say to people, old people say, no, that's not really true. Yes, yes, honestly, we pay people to do hips that don't work. No, you don't. Yes, we do. Surely not. Yes, we do. So actually, the nature of an outcome, it can be quite complex, but by and large, it doesn't have to be complex. And you can then construct a CCG, local authority, and NHS England commissioned contract that leads to those outcomes. The problem with that, which I think most people think is a good idea, is it is really radical. It transforms the nature of the organisations that are providing those bits. So, you know, frail elderly care in a hospital, if the hospital only got paid if the old person came out more independent than when they went in, they wouldn't often get paid. But actually, as we know, if you're in hospital for 20 days, you're likely to move to 5 different wards, which increases your likelihood of dementia. If you didn't get paid, they might well not do that in a hospital. So there are things, but it is immensely radical, and you need a reorganisation of provision. And again, we've been working on things which are called an accountable lead provider, where someone takes responsibility for holding this contract. So different forms of commissioning, different forms of provision, and then crucially, again, looking at Jeremy, what is different, having done a little bit of work internationally, what is different about this country is the major patient organisations are at the forefront of demanding this change. And we do not use them as consumers, as we do in other industries, to pull this change into different organisations. And so concretely, Macmillan's are putting some money into Staffordshire and Stoke CCGs to construct an outcome-based contract for end-of-life care and for cancer care. And this is them saying, and I think we could go through all of the major patient groups and find that they'd be in favour of doing this. So empowering them as a part of this organisation is. So I think the end point of this is. These are very, very big changes that take on 60 years of not just culture but organisation, and they need big changes to do, and it will cause ructions. Yeah. The last thing to say about the Commission, this is a cheeky thing to say, but hell,
your advice.
I'm allowed. I'm not sure London needs another plan. It's had quite a few. I think what needs to happen is we need to implement one. And I seriously think the way in which you work can change that, or it can not change it. So you need the last third of what you do to be talking to implementers. Not, you know, interesting people, but implementers, people who actually take this on board. And you need to work out with them whether they will do any of the good ideas you come up with. And if they don't, nothing much will happen.
So how do you make them do it?
You don't make them. Wrong word.
Right.
You cannot make them.
So
we've had an NHS in the past that's believed it can make them, and nothing happens. What you've got to do is find out that if you were to look at, and this would be a dreadful thing to do, it would take a few weeks of somebody's life, but go through all the commissioning intents of all the CCGs in London, and you'll find there'll be a lot about integrated care. Yeah. Bringing that together, you having a discussion then about the integration you want to do, and saying, how can we then corral that? I think the NHS has gone from telling everybody what to do to saying it's all down to them. And there's a world of difference between these two stances. Sure. And it's how you get amongst it, I think, and actually say, what are the things you want to do? There aren't many, again, with patient organisations, there aren't many organisations of commissioners, including local authorities, that don't agree with integration. It's just that how they do it, what are the barriers? And you will know the barriers around financial modelling that stops these things from happening. What can we all do? If you've got Monitor and the NHS England in a room and talk about a different form of financial modelling for a year of care, most people will be in favour of that. But it all needs to happen at once. Yeah. A set of plates needs to be in the air at the same time. And any individual group feels it's just not possible to do because the other plates aren't in the air at once. So what you can do is demonstrate that all of the plates can be got into the air at once, but other people are spinning those plates. All you're doing is helping to coordinate it.
Okay, thank you. Right. Any so we can pack up and go. Any?
No, that's not.
No, I'm just.
It works differently, and it's worth your while staying.
It's always nice.
Don't work differently.
I think.
Yeah. So I agree on the outcomes-based commissioning. What do you think, if we really were going to embrace that, Paul? What would that mean for the commissioning system in London in terms of its capabilities, and how would you see that developing? What should we focus on to make it capable of doing that?
I think when I've been working with, I talk about keeping plates in the air. When I've been working with CCGs to do this, I mean, 4 things need to happen at the same time. The first is, nearly all commissioners, nearly all GPs actually have somewhere near the back of their mind, wouldn't it be good to have some outcomes? The moment a lot of them got involved in commissioning, they found the tools they had to hand were all about inputs. So they think, oh, that can't be what this job is about. So inside people is a wish to do outcomes, but actually all the tools that are handed down by everybody are input tools. So what they want to do needs to be allowed and empowered. There then needs to be some tools which are actually about outcomes and simple ways of doing that. You know, if you want to do something around diabetes, then go and talk to local diabetes patients about what an outcome might be, and then try and work out how you construct a competitive dialogue, all sorts of things. These are all new skills for commissioners to do, but they can do it with a bit of help from CSUs that want to do that. So the third is they need a different piece of financial modelling. So in Mid-Essex, where I'm working, the GPs and everyone in the local area is working out what a year of care might look like. Now, so they could get some help with that, rather than actually having to do it empirically themselves. And lastly, it will lead to very different provision. And I think what we've seen in other parts of the country is that actually the major providers don't pay attention to all of this until the day before it starts to happen, and then they say, stop it. Because actually, this is a very radical change for them. And everybody needs to be preparing them that this is what the public want, and this is what we all expect, and we know it's going to be very difficult to do an outcome. So I think those 4 things need to be kept going all at once.
Thank you. Sam?
I wanted to focus, you sort of touched on it, this idea of fragmentation, and I want to specifically focus on the role of the consultant. What I've seen over the years is increased specialisation and a loss of that generous or holistic medical care. And certainly the complaints I get from my hospital consultants, particularly in urgent care, is there's just not enough general physicians and there's not enough A&E consultants. Tied in with actually some really good examples. So we have a diabetic consultant who works in a completely different way. He's on a mobile phone. We can directly access him for advice. He has shifted virtually all diabetic care out into primary care. This is in Tower Hamlets. And he comes around and does teaching sessions. And what's completely new about his contract is that effectively he's responsible for every diabetic patient in Tower Hamlets. And I imagine his first thought was, oh my God, how am I going to make this happen? But of course, what he did then was got rid of the fragmentation. My question to you is, how can we change the consultant contract in London, clinical excellence awards, appointment systems, to actually make this change happen and hopefully do what you're suggesting, which is get innovation from the grassroots rather than from the top down?
I think the interesting is if we stopped most of the current incentives, it would be a good thing. Because actually most of the current incentives are going in the direction of fragmentation. And again, the truth is, as you and I know, specialisation is not a bad thing. You know, it's achieved all sorts of things. The trouble is it dominates. It dominates the experience of care that the patient has. So what we need to do is organise specialists differently. And that means there's an organisation in the States called CareMore. The Americans do this. They've got a ridiculous name for these new consultants called extensivists, right? But extensivists are very high status consultants who actually are generalist consultants. So it seems to me what we've done is created very high status people that only get that status through specialisation. And we need to create very high status people that are generalists. And that can say to the specialists, actually the overall experience of patient care is more significant than your specialist input, and will be listened to. And for that, I think it does need, we need to incentivise consultants to see that a future, a high-status future can be there under generalism and not under specialism. We need to think about merit awards. We need to think about the organisation of hospitals, where it's still primarily body parts rather than actually the whole experience. I think we've got some in gerontologists and psychiatrists will be more likely to be outside the hospital, more likely to think about population health. So it's not impossible for consultants to do this, but it's actually it will take some change in the incentive structure for this to happen.
Paul, you've talked about specialists and specialism a lot and secondary care. One of the most consistent themes in all the London healthcare reviews going back to 1890 is this systematic fragmentation, poor scale, corner shop nature of primary care in London and all its associated facilities. What recommendations would you make for tackling the out-of-hospital agenda in London?
Well, I think one of the... I never know whether this is an unintended consequence of what's happened with CCGs or an intended consequence, but actually there is much more discussion around federation and relationship building amongst GPs that 3 years ago would not have done that. And it's partly because CCGs has brought together some peer-to-peer relationship. I think the models that are coming up are very, very tentative. I think what GPs tend to mean by federation is sort of quite loose. I think things could be asked of them contractually for GPs to be a part of a set of out-of-hours care, which would make it much more difficult for standalone organisations to do that. And so I think what we ask in other industries is that small organisations need to provide a range of services that go beyond their individual organisational base, and therefore they need to work together. And I think if that contractually was asked of GPs, you begin to create more powerful relationships. I think many of the federations I see are quite loose because actually GPs don't want to do this. They've learnt to work and live in a particular way, and they need to live to. So I think the contract is quite significant in that. I think the patient groups are really quite significant in that. I think if that contract. So if UK Diabetes was part of constructing a contract around diabetes care across a large part of London, then I think there would be in that contract for GPs a necessity to work together.
Okay, thank you. Thank you. Briefly, Jeremy.
Yes, some of the other stuff has been covered. I'm very interested actually in what you haven't said, because we had a previous session, Paul, which I think you were listening to, about the power of joined up IT. You haven't mentioned that as a factor in integration. I wonder whether do you agree with everything you heard previously, or do you think that maybe that is not where it's at?
Oh, I think the problem with gizmos is that they can be seen as the answer, and they're really important enablers, but not the answer. And I don't think the people who were here before were talking about it as the answer. I think they were talking about it as a part of a changed patient pathway. The crucial thing was a new patient pathway. And then, how do we get the IT to make that happen? And making that new patient pathway, in a sense, enforcing the pathway-ness over fragmentation is crucial. Then we look around for the sets of IT to do that. And I think, interestingly, in 2014, 15 and 16, the IT will get easier and easier to do that, whereas in the past, it actually needed a much more powerful set of interventions. Now I think but I do think we need to approach that with a patient pathway constructing a set of relationships rather than a piece of IT constructing a set of relationships.
Okay, Sam, very briefly.
Very quick question. Do you think there should be a London-specific GP contract, or part of London-specific GP contract, rather than the national contract?
I think there should be local elements to a national contract. I think probably I'd go down beneath London for that. So I think the difference between, I mean, having worked, I've been abolished 3 times, right? GLC, ILIA, and the SHA. So I really do believe in London-wide government, but actually, I think the localities that will make difference in a GP contract need to be smaller than London.
Paul, what do you think the mayor's role should be?
I think the mayor has
In health.
Sorry?
In healthcare.
In healthcare, I think the mayor has, it's the phrase that's been bouncing around in politics in the last few weeks, the bully pulpit role, right? That actually you have the right to stand up. It's a good thing that there are no direct relationships between the mayor and the National Health Service, that the mayor can stand up and make a number of, I expect this to happen for the people of London, sorts of comments. Okay. I'm really ashamed that this is happening and this is not happening for the people of London. I think the mayor has a platform to stand on to actually demand those sorts of things. And I think to also then, as was said by, I think, Paul and others in the previous comment, the big change that will happen in healthcare in the next 20 years, if it all works, is patients actually looking after themselves in a different way and more. And the mayor can play a very, very big role in that, in having a direct relationship with the public.
Yeah. Paul, thank you very, very much. You're always, you ignite passion. You talk about passion of fragmentation. I don't know what to call your passion, but thank you for being here. And we'll tap into your wisdom in the next few months. Would be wonderful. Thank you, Paul. So on this note, we're going to take about a 20-minute break, 15-minute, let's call it, before we come back. And it's been an amazing morning. Thank you.